Hi everyone, this is Tim, your instructor for the paramedic program, and today we're going to do chapter 13, which is fluid and electrolytes and balances and disturbances. I chose to do the PowerPoint from the book because I found that they did a little bit better of a job keeping things pretty simple, and which is the intent for this chapter. I will go through the book as I'm doing the voiceover to kind of point out charts and tables and things that I find that are very either interesting or important for you to know. I will tell you things in the PowerPoint that I find that are interesting to know, but not necessarily something you need to know, or I find that the book actually did a better job explaining it to you than I would. So, but again, I'll point out these things as we go throughout the PowerPoint. So for fluid and electrolyte balance, it's necessary for life, and it's also necessary for homeostasis. I use the example of someone who is dehydrated. If your body is dehydrated, something in your body will actually kick in the thirst factor, which will then make you thirsty and you'll want to drink more fluids. Once you have become hydrated by the amount of fluids that you have consumed, homeostasis is actually balanced. So basically for me, in a nutshell, homeostasis is the balancing of between things that have gone wrong and your body doing things to actually fix it. The role of the nurse is to actually help prevent this. So if you have a patient who is dehydrated, or let's say you have, someone who comes in from out of town and has never experienced the Arizona heat before and wants to go hiking, you know to tell them to start drinking a lot of fluids, take fluids with them, make sure that they hike more in the morning or late in the evening after the sun has gone down or when it's cooler out. So you're doing something to prevent that from happening. Now, if a patient does come to you that's dehydrated and they can't seem to fix it, then you actually treat them with fluids. And because usually when patients are dehydrated, they're actually low on electrolytes, your job is to actually replace that also. And as we go through the chapter, I'll point out which electrolytes I find that are either important or I probably have some sort of story behind each one of them. So approximately 60% of typical adults are made up of fluid. This will vary based on age, body size, and gender. So grandma who's 90 is probably going to have less water than someone who is roughly 25, probably 6'1", and let's say 250. Gender also plays a big role in this also. So things that are good for you to know is intracellular fluid and extracellular fluid. These are actually found in the book. They do a better job explaining it than I do. I find that this is good to know, and I want you to understand it. But it's not. I'm not going to go into much depth of it because those are things we will probably go into later on as this PowerPoint goes on. What I do want you to understand and know is third spacing, the loss of extracellular fluid into space that does not contribute to equilibrium. So this is the patient who is severely edematous, pathologist resistance once it's actually gone through the vascular system, once it's gone through the interstitial space. When there is nowhere else for fluid to go, it will go to the skin. Again, these are the patients who are very edematous. Their skin is very taut. It's very swollen looking, and they tend to weep. Basically, it means that it's just again, there's no place for the solution to go or the fluid, and it just starts to kind of leak. And that's extracellular fluid that in the third spacing is the skin. So again, this pathologist resistance has got nowhere else to go, and basically you just become swollen. So for electrolytes, active chemicals that carry positive cations and negative anions that are electrical charged. Major cations are sodium, potassium, calcium, magnesium, hydrogen. And the major anions are chloride, bicarbonate, phosphate, sulfate, and protonate. I do want you to know and understand what it means to be hyper and hypo of these electrolytes. So for sodium, potassium, calcium, magnesium, and chloride, phosphate, those are the ones that I really want to be specific about. If you go to page 246 in chapter 13 in your book, between 246 and 247, and they do a very good job as far as laying out all the electrolytes and what it means to be hypo and hyper, and what the symptoms are. And what I want you to do is actually concentrate on knowing what the symptoms are, how they actually affect the body, and then what we as a nurse will actually do, because it's all about the interventions and actually correcting the problem. Regulation of fluid is the movement of fluid through capillary walls, and this depends on hydrostatic pressure and osmotic pressure. The direction of fluid movement depends on differences of hydrostatic and osmotic pressure. So I want you to understand this, and this is in your book. They do a better job than I do. But I don't want you to go in too much in depth, because when we start actually doing like normal saline, half normal saline, D5, and 3% normal saline, once we do those fluids, we'll go into more depth. So again, I want you to be able to read in the chapter and understand them, but once we start putting all the things together, you'll understand a little bit better. So osmosis is the low solute concentration to an area of high solute concentration. Diffusion is a solute that moves from an area of high concentration to a lower concentration. Filtration is movement of water and solutes that occur from an area of high hydrostatic pressure to an area of low hydrostatic pressure. And then active transport is the physiological pump that moves fluid from an area of low concentration to one of higher. So again, this is in the book. Understand it, but again, we'll go into more detail, whether it be class or as we do more PowerPoints. What I want you to understand as far as active transport, the sodium-potassium pump, it maintains higher concentration of extracellular sodium and intracellular potassium. So basically what this means is that there is a cell with fluid around it. Whatever is in the cell, if it wants to get out, it will actually probably exchange something that is on the outside of the cell for something that's in the inside. So for the sodium-potassium pump, basically the sodium that's outside wants in, and then in order to do that, it will actually trade with the potassium. This actually requires ATP, which is used for energy. Again, understand from the book, but that's pretty much what I want you to understand. And as we go through stuff, we'll explain a little bit more. So as a question, is the following statement true or false? Osmosis is the movement of a substance from an area of higher concentration to one that is lower. And the answer is going to be false. Diffusion is the movement of a substance from an area of high concentration to one that is lower. So routes of gains and losses. So this is where the meat and potatoes of the chapter start coming together, and this is where I can actually explain things a little bit better for you. So to gain, in order to actually gain fluid and electrolytes, it's going to be consist of either dietary intake, whether it be fluid, food, or internal feeding. Internal feeding is more like your G tubes, your NG tubes, duo tubes, tubes that go into the body, either into the stomach or the intestines, and you're feeding liquid through that. Or parental fluids, which is basically an IV. And it's the bag that has every fluid and electrolyte that you possibly can imagine, and what the body actually needs. And they're usually the one for the IV is usually given for patients who don't have a gut that either moves based on peristalsis or it actually doesn't absorb at all. And the only way you can do it is by IV. So for loss, this could be due to kidneys, which is basically you urinating. What goes in must come out. It also could be due to skin loss or through skin loss, which is basically either sensible or insensible. This is mostly you being outside and sweating. Fluid is going to be excreted, and that's how you lose it. It'd be through the lungs, which is you basically inhaling and exhaling and losing moisture that way. It can be through the GI tract, which is basically either through diarrhea or as waste is being passed, it will draw fluid to help pass it, or it will pull moisture and you'll lose it that way. So what is the average daily urinary output in an adult? And the answer is 1.5. Vital to regulation of fluid and electrolytes, the kidney's normal filter of 170 liters of plasma every day in the adult while excreting only 1.5 liters of urine. So basically what this concept means is that the kidneys filter out what it needs and what it doesn't. And once it's all said and done, 1.5 liters is the waste in the urine. I also want to bring up the fact that I'm very big on input and output. So your patient, a normal person, will usually urinate about 30 cc's an hour. And the reason why I say this is because what goes in must come out. And if your patient is consuming a lot of fluids and the the amount that goes in is not equaling what's coming out, or if your patient drinks a lot of fluids and what is coming out is more than what they were consuming, then there's actually something wrong. Now, that could either be fluid volume overload, that could be dehydration, that could be a kidney issue. There's several factors, but that to me is very important for when it comes to electrolyte balances, kidney functions, cardiac functions. So it's not just a matter of what comes in and goes out is a minor thing. It really does affect a lot of different bodily systems, and we'll go through those as we go through on. All right, so this is actually found in your book. Again, it's good to know, not necessarily something you need to memorize, but it's the process of the kidney and how it really truly filters out and keeps what it does need and excretes what it doesn't. So gerontological considerations, so for the elderly population, reduced homeostatic mechanisms are cardiac, renal, and respiratory functions. Again, what goes in needs to come out, and what doesn't come out is going to either be filtered through the kidneys again, it's going to affect the way the heart works, or the respiratory function itself. Decreased bodily fluid percentage. So again, the older that you are and the smaller the grandma is, the less she's actually going to be having enough fluid. And then there's also medication use. This could be Lasix, aldactone. There are several medications that are designed to actually pull fluid out of the circulatory system, filter through the kidneys, and actually be excreted. Too much of those can actually make someone dehydrated. Sometimes dehydration is not a bad thing. I've had renal patients that are on dialysis, and for them to be dehydrated, it actually makes things a little bit better for them. Patients who have congestive heart failure or the chance of being fluid volume overload, giving them a certain amount of medications and making them just a little dehydrated makes their heart work a little bit better and more efficiently and without causing more stress on it. And then also a problem with elderly people is the presence of contaminant conditions. And this could be anywhere from C. diff, which causes diarrhea, and someone who doesn't already have a lot of fluid in their body. So grandma who's 90, who weighs about 80 pounds soaking wet, all of a sudden gets severe diarrhea from either something she ate, or maybe she's taking an antibiotic for a urinary tract infection and developed C. diff. Well, the more diarrhea that she has, the more fluid she's actually going to lose. And in someone who's already dehydrated is going to be even more dehydrated. Electrolytes that actually follow that are sodium and potassium. So grandma who has severe dehydration and diarrhea for about a week, once you start looking at her labs, you're going to find that sodium and potassium are going to be very low, and those affect other areas. So you'll look at the other symptoms, and you'll look at her, and you'll look at what needs to be done to actually fix those issues. So here's fluid volume imbalances. So you can actually have hypovolemia, which is not enough fluid, and you can actually have hypervolemia, which is an excess of fluid. So for volume deficit, it's the loss of extracellular fluid and exceeds intake ratio of water. Electrolytes lost in some portion as they exist in the normal bodily fluids. So I am also a big believer that water follows salt and salt follows water. So when you do have grandma who has had severe diarrhea and she's losing a lot of her hydration, she's also going to lose a lot of salt. And that's going to be through and it can be through urine or it could be through diarrhea. But I'm just using the example is that as orifices try to expel fluids, trying to rid of what ails them based on trying to maintain homeostasis, the electrolytes will actually follow. For dehydration, it's the loss of water along with increased serum sodium levels. So again, if you're actually losing a lot of fluid, whether it be through urine or through your bowel movements, the sodium follows, but sodium being retained in the body will allow it to retain fluids, which makes you hydrated. This may occur in combination with other imbalances. So again, when you start affecting the kidneys or you start affecting the bowels and you start losing the fluids, it starts to affect the heart and the lungs and other organs. So dehydration, a cause could be fluid loss from vomiting, diarrhea, GI suctioning, sweating, decreased intake, inability to gain access to fluid. So let's make this very simple. If you're dehydrated, then drink more water. And the more water you drink, the more hydrated you become. But if you do actually have someone or a patient that is vomiting a lot or having a lot of diarrhea, they are going to be losing a lot of their fluids and becoming dehydrated. GI suctioning is when you actually have an NG tube down someone's nose, and it goes up their nose, down their throat, and into their stomach. And you tend to do GI suctioning for people who have small bowel obstructions or are producing too much stomach secretions, and it makes them very nauseous. So if you can suck them out, then it keeps them from throwing up, or it actually gives their bowels a rest for them to be able to heal a bit quicker. The more you suck out, the more your stomach will continue producing secretions. The more you suck that out, the more dehydrated you get. And again, when bodily fluids are being removed, you're also losing your electrolytes. Risk factors are diabetes insipidus, adrenal insufficiency, osmotic diuresis, hemorrhage, coma, or third space. So again, this is basically for whatever reason your body is losing fluid for some reason through an orifice, and it's causing you to be dehydrated. Manifestations could be rapid weight loss, decreased skin turgor, oliguria, concentrated urine, postural hypotension, rapid weak pulse, increased temperature, cool clammy skin due to vasoconstriction, lassitude, thirst, nausea, muscle weakness, and cramps. All right, so let's break this down pretty simple. So the rapid weight loss, decreased skin turgor, oliguria, and the hypotension and the weak pulse, those are due to the fact that you are dehydrated. The best way I can explain hypovolemic shock is due to the fact that you do not have enough fluids. Your body will actually go into a mode that will constrict your blood vessels to be able to retain as much fluid into the core center of the body as it possibly can. That will cause hypotension. And in order for it to move around, your heart rate will actually speed up. So basically, blood pressure drops, heart rate goes up, and the cool clammy skin is because of the fact that your body is trying to conserve whatever it does have into the center core of the body, so it's going to vasoconstrict everywhere else. The patient should, if things are going well everywhere else, they should actually be thirsty. Because again, based on homeostasis, their body is actually trying to fix the problem. The muscle weakness and the cramps is either one, lack of circulation, or two, if it's actually got to the point where if they've lost enough fluid and electrolytes, based on what you found on 246 and 247, as far as for potassium and sodium, you actually start having muscle cramps because those are symptoms of lack of specific electrolytes. You as the nurse are going to look at labs. One of them is going to be an elevated BUN in relation to the serum creatinine and an increased hematocrit. And remind me in class so I can go over that. And it's easier for me to show you than it is for me to tell you. Certain electrolyte changes may also occur. So again, basically whatever orifice is losing the fluid is going to also lower your electrolytes. Medical management is going to provide fluids to meet the body needs, and this there can be have grandma drink more fluids or actually an IV solution or a combination of both. Elderly people who do not have as good of a thirst factor as the rest of us, they just need to be reminded to drink, and they're like, well, I'm not thirsty. Well, you're old, and that's because you're lacking it. So if they're at the bedside, go in there every hour and have her drink half a cup of water, or big gulps or some sips. You just got to constantly remind them to continue drinking. The IV solution is to help hydrate them a little bit faster, but again, once your patient starts to urinate a lot, based on the fact that what goes in comes out, then you can actually tell that she's becoming hydrated, because if they equal each other, then she's hydrated. If you don't get much out when you first start, it's because she is hydrated and her body is actually trying to absorb as much as you possibly can give it. But you don't want to do too much, because if you give her too much and her body can't handle it, then it will actually start to absorb more than it needs to, and then she'll actually turn into the spacing, or the fluid will actually go past least resistance and causing other issues, whether it be cardiac, respiratory, or kidney problems. Fluid volume deficit and nursing management. So things that you're going to do on a daily basis. You're going to do eyes and nose. Again, you want to make sure that what goes in comes out. You're going to do a daily weight, because if grandma starts to gain weight, it's because she's gaining the fluid back. If she starts rapidly gaining more weight, then you're giving her too much and she's retaining too much. If you aren't giving her enough and she's still dehydrated, then she'll actually lose weight daily. You're also going to do vital signs, and the reason why is because if you do a set of vitals and you find that her heart rate is high and her blood pressure is low, then she is truly dehydrated. Monitor for symptoms of skin and tongue turgor, mucosa, urine output, and mental status. The reason why you check for the mucosa and the skin and tongue turgor is because those are your first signs of dehydration. You can actually see if she's dry in her oral mucosas, then she's actually truly dehydrated. You're going to check for urine output, because again, what goes in should come out, and if she's not putting anything out, then she is truly dehydrated. Mental status is because if she is truly dehydrated and there's not much fluid floating around diluting all of the waste that her kidneys is starting to flush out, then her body's slowly becoming poisoned. Or if she's actually urinating too much or her sodium level is too low, then one of the symptoms of sodium being low is confusion. So from a mental status changed, then you can kind of start ruling out some stuff, and it's probably more of a sodium depletion and dehydration than anything else. You're also going to measure to minimize fluid loss. You want to make sure that what goes in comes out. You can put a hat in the toilet. You can put her on bedside commode. You can put her on a bedpan. You can do whatever you can to actually measure it, because, like I said, you really do want to see what goes in is actually coming out. You want to do some oral care, because if her tongue and her mucous membrane orally is very dry, the oral care will actually make her a little more comfortable. You want administration of oral fluid, so get her to drink more water and electrolyte drinks that will replace them. And you can also do peritoneal fluids. I think this is more of a last resort, because of the fact that you're starting to kind of, not want to say chemically changing her, but once you start stopping things that are normally something that she's used to, like swallowing and drinking, and her stomach absorbs, and so is her GI tract. Once you start taking those things away from them, they start to kind of take too long for them to come back. So you don't want to start something that might cause a problem further down the line. So what is the major indicator of extracellular fluid volume deficit? And the answer is drop in postural blood pressure. Fluid volume deficit signs and symptoms include weight loss, decreased skin turgor, oliguria, concentrated urine, orthostatic hypotension due to volume depletion, a weak rapid heart rate, flattened neck veins, increased temperature, thirst, decreased or delayed capillary refill, decreased central venous pressure, cool, clammy, pale skin related to peripheral vasoconstriction, anorexia, nausea, muscle weakness and cramps. Clinical manifestations of fluid volume excesses result from expansion of the extracellular fluid and include edema, distended neck veins, and crackles, which is in the lungs. All right, so for fluid volume excess, due to fluid volume overload or diminished homeostatic mechanisms. So basically the excess means that you've actually given too much and she's retaining it. Risk factors are heart failure, because your heart's not pumping efficiently and it's not moving things around, so things are starting to become stagnant, or based on patholytic resistance will start to absorb in other areas and stay. Another risk factor is renal failure, because if the kidneys aren't functioning correctly and they're not filtering, then you have poison that's truly floating around in your bloodstream, and there's not enough to be able to get it out. And with too much fluid volume excess, basically at that point it pathways resistance, you're going to start swelling. Another risk factor is cirrhosis of the liver. Contributing factors are excess dietary sodium, because water follows salt. So if you start salting all your food or consuming too much sodium, then you will actually start to retain too much fluid. Or sodium-containing IV solutions, and we'll go over that as we go through the fluids. Manifestations are edema, distended neck veins, abnormal lung sounds, which are crackles, tachycardia, increased blood pressure, pulse pressure, increased weight, increased urine output, and shortness of breath and wheezing. So let's see here. Let's start with edema. We already know, because the fluid didn't really go anywhere except for stayed inside, so you start to swell. Distended neck veins is because of the fact that the fluid is too much for the vascular system. With that, it actually causes the blood pressure to go up. And of course, your heart is trying to beat as efficiently as possible, so it's going to increase that also. You have an increased weight because of the fact that the fluid has nowhere to go and it's not coming out. So as when we went back several different slides, the measurement of weight loss or weight gain, or the measurement of having dehydration or being hydrated, is weight loss or weight gain. So if you do eyes and nose and you weigh your patient daily, it'll give you a pretty good indicator of whether or not they're actually hydrated or not, or if they're getting too much hydration or they're not getting enough. The shortness of breath and the wheezing is because of the fact that based on pathless resistance, if you give someone too much fluids and it has nowhere else to go, one of the places is either the skin or it'll go to the lungs. So if it goes to the lungs, it's basically you're drowning them, essentially. And that's where you actually hear the crackles. Medical management is going to be directed at the cause. So if it's a kidney issue, then you're going to try to fix that, whether it be dialysis, whether it be medication, whether it's actually backing off on the amount of fluids you're giving them. You can restrict how much fluid and sodium you're giving them, and you can also give them diuretics. So you can give the Lasix and the aldactone and things that will actually cause the kidneys to flush out more fluid, so that way they can get rid of it. So nursing management, eyes and nose and daily weights. You're going to assess the lung sounds, because if they sound crackly, then you know that they're actually starting to drown. Edema, so you're going to look at the skin. You're going to check whether or not they're swollen. You can also do the pitting test, which is basically grab your patient and hold it for a couple seconds. And if you find that when you let go, your fingerprints are still on them, or the indentation of where your fingers were, then they truly are edematous, and that's third spacing. Monitor responses to medications. So the diuretics, again, you want to do eyes and nose. So you give grandma, Lasix or aldactone, and you're going to start measuring her urine output to make sure that there is enough coming out. If you give her Lasix and you don't measure much, then you know that it's not working. Either try a different medication or try to find out if there's actually something else wrong. You're going to promote adherence to fluid restrictions, so there's no point of taking a patient who is in fluid volume overload and allowing them to continue consuming more fluids, whether it be IV or orally. Patient teaching related to sodium and fluid restrictions. So I've had patients who are in fluid restrictions and they have literally drank out of the toilet, because that was the only place that we didn't cover to make sure that they didn't drink anymore. Desperate people will do desperate things. So you actually have to teach them, based on you're on this, fluid restriction, because you will not get better if you don't stop consuming so much. And we're not taking it away from them completely. We're just putting on, 1200 cc fluid restrictions for a 24-hour period. So that's all they get to consume. You also want to teach them about their sodium. You can tell them not to salt their food as much as you want to, but if they go home and they actually buy the salt substitutes, then you're finding out that it's actually just as bad. It has a lot of potassium in it. And again, you want to make sure that, you're teaching them everything they really kind of need to know and understand, so that way they can go home and continue doing it, because if not, they're coming back a week later in fluid volume overload. Avoid sources of excessive sodium, which we talked about, including medications. Promote rest. I think the reason why is because once you have somebody who is that swollen, the best thing you really can do is have them lay flat with their legs elevated. Not only does that promote vascular, return from the feet to the heart, but it also, by them not doing as much strenuous activity, doesn't put more stress on the heart, which is already having stress from the amount of fluid it has to pump. Semi-Flowers position or orthopenia. Oh, for orthopenia. So you're going to actually put them in semi-Flowers for shortness of breath. If they're in fluid volume overload and they do sound crackly, sitting them up a little higher allows them to breathe a little bit better. Skin care, because the third spacing and the edema from the skin will actually break down and tear very easily. So you want to minimize this, or you don't want it at all. But repositioning them and turning them every 2 hours will help promote the ability for them not to lay on one particular area of skin and break down. So if you rotate them every so often, at least, like I said, every 2 hours, it's best for their skin. And it shifts the fluid around a little bit too. All right, so electrolyte imbalances. We have sodium, we have potassium, calcium, magnesium, phosphorus, and chloride. Again, these are on page 246 and 247 of your book. So with sodium, it's a serum sodium less than 135. The causes can be adrenal insufficiency, water intoxication, which means they just keep drinking as much water as they possibly can, and that could either be because they're so thirsty that they don't realize they're drinking that much. We also have another cause, which would be SIADH, or losses by vomiting, diarrhea, and sweating, and diuretics. So having not enough sodium is because of these, or could be because of these reasons. So a serum level less than 135 is going to be hyponatremia. Things you're going to look for is poor skin turgor, dry mucosa, headaches, decreased salivation, decreased blood pressure, nausea, abdominal cramping, and neurological changes. Medical management is going to be water restriction and sodium replacement. So you don't want them continuously drinking more water, because the more water they drink, the more you're diluting the amount of sodium they actually have. And you also want to, I've actually given patients salt tablets, which is basically a little chunk of salt, and they take it 3 times a day to get their sodium increased. You can also put them on fluids that have more sodium in them. You can also salt their food. It's as much as we tell people not to salt their foods, it's more for health reasons, but when you don't have enough sodium, then you do need to add it where you can. Nursing management is going to be assess and prevent. This can be dietary, sodium, and fluid intake. So again, we want to be able to give you a little more sodium into your system, whether it be dietary or through fluids. Identify and monitor at-risk patients. So the patients who could be at risk are those ones who have the SIADH, which is a kidney issue. Or you can actually have patients who have had neurological problems and damage that could cause them to have low sodium. And certain medications, the diuretics, like giving Lasix and naltrexone, the reason why you give them is to actually get the water off. It's a water pill. But again, the more water you get off, the more sodium actually follows. So if you have somebody who is low on sodium and you're about to give them a Lasix pill, you might want to kind of check first to see if you still want to give it. All right, so hypernatremia. This is sodium greater than 145, and the cause of this could be excess water loss. Because what's happening is that, and not always, but as I've told you guys before, when you lose a lot of water, you lose a lot of salt. Well, there are certain cases where if you actually lose a lot of water, you do not lose the salt. And with that, your urine or your bloodstream gets very concentrated and your sodium level actually goes up. Excess sodium administration. I have a dad who literally salts his food like you wouldn't possibly believe. In fact, he salts his salad. So putting too much salt on stuff or consuming sodium will actually cause it to go up. We got diabetes insipidus, heat stroke, which basically means you're dehydrated and what's left over is sodium. We also have hypertonic IV solutions. So these are your 3% sodiums in IV solutions that will cause your sodium level to go up. Things you're going to look for are going to be thirst, elevated temperature, dry, swollen tongue. You got sticky mucosa. We got neurological symptoms. We got restlessness and weakness. So here's a special note. Thirst may be impaired in elderly or the ill. So as I mentioned before, grandma and grandpa, they don't necessarily have the same thirst factor that we do. So sometimes they just don't feel thirsty, and that's why they don't drink enough. By them being dehydrated, it causes their sodium level to actually go up because of the concentration. Medical management, hypotonic electrolyte solution, which would be D5W. Nursing management is going to assess and prevent. So you're going to assess for over-the-counter sources of sodium. Not sure off the top of my head which medications are high in sodium, but they could be. And if you don't ask, they don't tell you. So when you're going through your health history to find out why they actually have a high sodium level and you're not really quite figuring it out, a lot of times they don't believe that over-the-counter medications are a true medication, so they don't really tell you unless you ask. Offer encouraged fluids to meet the patient's needs. So again, grandma and grandpa who have a sodium of, let's say, 150, may need to start drinking a lot more fluids, and that's when you start reminding them and offering to them every hour or so. Provide sufficient water for tube feedings. So a patient who has either an NG tube, a duo tube, or a PEG tube that's getting feedings through them, they're getting nutrition, but they're not necessarily getting hydration. So you might actually do a water flush. So let's say you put the tube feeding on for 4, 5, 6, 7, 8 hours, and then after the 8th hour, you can actually give them, let's say 100 cc's of water. It's just tap water. You put it through the tube, it actually goes into their gut, and they absorb what they actually need. A lot of times we forget about that, and we don't give them enough, and they become dehydrated because of it. So hypokalemia, this is below normal serum potassium level, so anything less than 3.5. And this, see here, may occur with normal potassium levels with alkalosis due to shift of serum potassium into the cells, which we'll go over later. But what I really want you to know is more that hypokalemia is the fact that it's less than 3.5. And this could be due to GI losses, like diarrhea. It could be due to medications. There's certain water pills that do not absorb the potassium and lose the fluid. So medications can do it. Ulcerations of acid-base balances, hyperaldosteronism, and poor dietary intake. You'd be surprised at how many people just don't consume enough potassium. I had a patient this last weekend who was an alcoholic. He drank most of his meals. He loved his vodka, and his potassium was 2.8, so I kept chasing that all day long, and finally got it back up where it needs to be. Things to look for is fatigue, anorexia, nausea, vomiting, dysrhythmias, muscle weakness, cramps, paresthesia, glucose intolerance, decreased muscle strength, and I'm not quite sure what DTR is. The reason why you're looking for the fatigue, the dysrhythmias, muscle weakness, and cramps, and paresthesia is because of the fact that your body needs potassium for muscles to work, and the heart is a muscle. So again, if you're actually not having enough potassium, you could have dysrhythmias because that muscle isn't pumping well enough. The weakness and the cramps and the paresthesia is because of the fact that you have not enough. That's why if you have patients or if you know people who have a lot of leg cramps, most likely it's because their potassium is not high enough. The fatigue, anorexia, the nausea and vomiting, I mean, these all kind of go hand in hand. So if they're having a lot of diarrhea and a lot of vomiting, you might want to check their potassium level just to see how much potassium they're truly losing. Medical management, increased dietary potassium replacement, and IV for severe deficits. So you can actually give IV solutions with potassium in them. And the patient I had yesterday, I literally gave him 100 cc bag of potassium. So I literally just gave one, ran over an hour. It went in IV, and I had to wait a couple hours, gave him another one, and then a couple hours later I tested him and he started coming back up. Nursing management is going to assess. Your biggest thing is putting eyes on your patients because, again, if they're actually having the fatigue, they're actually having the muscle weakness and the cramps, you can start to kind of think the idea maybe is that their potassium is too low. severe hypokalemia is life-threatening, and that's because your body does need the potassium to function. You're going to monitor ECGs and ABGs. So for someone who does have less than 3.5, again, it could cause dysrhythmias, and an ECG or an EKG can actually tell whether or not something is not beating correctly. You're also going to give them dietary potassium, so start feeding them bananas. Things that are high in potassium will work. Nursing care is related to IV potassium administration. So again, you can give 100 cc bags of potassium every hour until it comes back up. So hyperkalemia is the idea that you're having too much potassium. It's higher than 5.0. Causes usually are treatment related: impaired renal function, hypoaldosteronism, and tissue trauma and acidosis. So let's see here, cause could be treatment related. So if you actually do give, my guy had potassium 2.8, and let's say I gave him a couple, and all of a sudden his body started absorbing all the potassium I gave him, he could go from 2.8, which is hypokalemia. It could truly go into hyperkalemia just because of the fact that I gave him too much. Impaired renal function, because again, your body actually will filter what it doesn't need and actually urinate it out. If the kidney is not functioning correctly, it could potentially filter that potassium through several times and put it back into the bloodstream, which causes the actual bloodstream to have too much. There's something not clicking that your kidneys are going, hey, I don't need this much, and it starts to filter out more. Tissue trauma, so when there is trauma to tissue, it will actually release potassium into the bloodstream. Things to look for is cardiac changes, because again, if you don't have enough or if you have too much, it causes the heart to either beat too much or not enough, or correctly or incorrectly. And muscle weakness with potential respiratory impairment, paresthesia, anxiety, GI manifestations. So it basically sounds like the same. You really just want to be in that position that you're between the 3.5 and the 5.0. Not enough causes all these symptoms, and it sounds like having too much causes the same symptoms. Medical management is going to monitor ECG, so you can put your patient on a telemonitor to find out if things are continuously beating correctly. Limitation of dietary potassium, cation exchange resin, so kaaxylate. So what that does is you basically give your patient this really disgusting, nasty tasting liquid, and they drink it, and about an hour or so later they have severe diarrhea, which keeps cleaning out their system, and with that it will pull the potassium out and dispose of it. So the more diarrhea they have, the more of the potassium they lose. You can also give IV sodium bicarbonate, which can also help with the kidneys and buffer that out and pull the potassium out. IV calcium gluconate, which does the same thing. Regular insulin, so the more insulin you give, the more potassium is actually pushed back into the cell, so it causes the potassium level to go down. You can also do hypertonic dextrose IV, and you can do B2 agonist, which is like your Zantac and your GI pills. And you also do dialysis. Dialysis will basically pull out everything that it needs, flush it, and push it back in. Nursing management. So you're going to assess assessment of serum potassium level. You're going to mix IVs containing potassium well. Which we don't really do that much. And the reason why they say this is because if you are mixing medications for yourself instead of the pharmacy, if you don't mix it well and they tend to bind together, you're going to increase your potassium too fast as opposed to it being evenly distributed throughout the solution. Again, we don't do that much. Minor medication effects, dietary potassium restriction, dietary teaching for your patients at risk. So again, they can come to the hospital, you fixed them, but if you don't really teach them what caused it and what to do when they get home, they're just going to come back with the same problem. Hemolysis of blood specimen. Okay, so basically you draw some labs, you send them down to the lab. The lab went to actually spin it to find out how much potassium is really in it, if it wasn't drawn correctly or it actually coagulated, or you didn't draw it from in the right needle. You can actually hemolyze the blood specimen itself, and that will actually cause the lab to be off. So it's true. It could be likely. It's not. I mean, it's not enough that I would have thought about this if the slide didn't have it. So it's possible. Another reason why you could be hyperkalemic is because of salt substitutes, because they are high in potassium. Medications may contain potassium. Again, if you don't ask your patients, they don't tell you. They also could take over-the-counter potassium, and if they get cramps and, the, you know, neighbor Judy told her that if she took potassium pills, the cramps would go away. And next thing grandma's in with a potassium of 5.5 or 6 because she just kept taking the potassium pills because that's what someone told her to do. Potassium-sparing diuretics may cause elevation of potassium. So basically, the potassium-sparing diuretic means that you give a water pill. The kidneys actually flush all the fluid out, but what it does is it recycles the potassium and puts it back into the bloodstream, so it's potassium sparing. If they're high and they keep taking the same pill, which actually continuously spares the potassium through the urine, and it keeps cycling it, then they just keep getting higher and higher. Should not be used in patients with renal dysfunction, because if the kidneys aren't working correctly, then you shouldn't be giving meds that are created by the kidneys. So question, is the following statement true or false? The ECG change that is specific to hyperkalemia is a peaked T wave. And the answer is true. The ECG changes that are specific to hyperkalemia are peaked T waves, wide flat P waves, and a wide QRS complex. The ECG changes that are specific to hypokalemia are a flattened T wave and the appearance of a U wave. Do I expect you to know this? No. Is it nice to know and understand that with either too much potassium or not enough potassium, it will cause dysrhythmias and the heart rhythm to change? Yes, that's good to know. So hypocalcemia, serum level is less than 8.6, must be considered in conjunction with serum albumin level. Causes could be hypoparathyroidism, malabsorption, pancreatitis, alkalosis, massive transfusion of citrated blood, renal failure, and medications. The massive transfusion of citrated blood, so basically that means is that when you draw from a donor a unit of blood, that bag that the blood collects in it actually has anticoagulation additive added to it. What that does is it actually binds to the blood and it keeps it from coagulating, which makes sense. But when they actually spin it all out and take what's in that blood out and donate it to different people, that coagulation is still there. That anticoagulant medication or the solution is still there. So when you actually transfuse blood to someone, they're actually getting not only the packed red blood cells or the plasma or the platelets, but they're also getting the anticoagulant. It's not enough to hurt them, but if you do massive amounts of transfusions, they will start to get more and more, and that actually causes their potassium to go down because it binds to it. In a nutshell. The hypoparathyroidism, the parathyroid is actually what controls the calcium level in the body, and if it's not working correctly, it will cause them to not produce enough, or actually pull enough out of the bone and put it into the bloodstream. Malabsorption, so basically, you're drinking a glass of milk and your body doesn't really like it too much, and it starts to cause either diarrhea or doesn't want to absorb it, then you're not really drinking and consuming what you and retaining what you actually consumed. Things to look for are tetany, circummoral numbness, and that's due to the fact that the anticoagulant is binding to the calcium. The calcium is actually being excreted. Paresthesia, hyperactive DTRs, the Trousseau sign, Chavstek sign, which I believe are found on page 259. And it's actually in figure 13-6. The lack of calcium can also cause seizures, respiratory symptoms of dyspnea and laryngospasm, and abnormal clotting, anxiety. Medical management is going to be give IV calcium gluconate, calcium and vitamin D supplements because you need one in order for it to absorb the other, and then also the diet. So, I mean, maybe your patient can't actually afford food that are high in calcium, and so it really could be a diet-related issue as opposed to anything else. But you're going to give them calcium gluconate, but you're also going to monitor your patient very closely when you give calcium gluconate because you're directly giving them calcium, and because calcium does so much with the body as far as the way it affects it, you just got to be able to watch for symptoms that may be leading to the fact that they went from having not enough to getting enough, and then you gave them too much. So that's what you'll look for. Nursing management, assess your patient. Again, you want to make sure that they either have enough or not enough, have enough or don't have enough. Severe hypocalcemia is life-threatening. Weight-bearing exercise to decrease bone calcium loss. Patient teaching related to diet and medications, and nursing care related to IV calcium administration. So again, if you don't teach your patient why they're there, what caused it, and how to fix it, then they're just going to keep doing the same problem over and over. Here's your Trousseau sign, and this is caused from lack of. You put the blood pressure cuff on, you squeeze it, and it actually causes the muscles to retract like that. So hypercalcemia, which is a level greater than 10.2, causes could be a malignancy or hyperparathyroidism, which now means that your body is actually producing too much calcium to cause it to go into the bloodstream. Bone loss related to immobility. So basically when the bones aren't working or your body doesn't believe that they actually need as much calcium to stay strong, it will actually pull it out and put it back into the vascular system. Reasons could be, or things to look for are going to be muscle weakness, incoordination, anorexia, constipation, nausea and vomiting, abdominal and bone pain, polyuria, thirst, ECG changes, and dysrhythmias. I think the polyuria is probably more because your body's trying to create homeostasis by urinating out. So it's probably trying to do what it can to get rid of it. Medical management is going to be treat underlying causes. So you can do fluids, you can do furosemide, which is Lasix. You can also do phosphates, calcitonin, and biphosphonates. Nursing management is going to do your assessment. Again, you're always looking at your patient first and see if you see any signs or things that are different than they were before. You're going to do hypercalcemic crisis. Let's see here. Hypercalcemic crisis has a high mortality rate, which makes sense. Encourage ambulation, because the more they move around, the more their bones need to be strong. Your body will actually think that it needs to pull it back into the bone and out of the bloodstream. Fluids of 3 to 4 liters a day provides fluids containing sodium unless contraindicated. So I believe that the more you dilute the blood, the less the calcium is going to be concentrated. And you want to do fiber for constipation, and you want to ensure your patient's safety. Because again, if they have too much calcium in their blood, they don't have enough in their bones, which means if they fall down, they're going to break. All right, so slowly but surely, we're getting halfway through this book and this PowerPoint. Hypomagnesemia. So it's a serum level less than 1.3. It's evaluated in conjunction with serum albumin. The causes could be alcoholism. So again, the patient I had this last weekend that liked to drink his meals with, well, actually he just drank all of his meals and it was vodka was his alcohol of choice. His potassium or his magnesium level was 1.8, which wasn't bad, but it's not great either. Another cause could be GI losses, and again with him being an alcoholic and as much alcohol as he drank, he actually had diarrhea all the time, and that's probably one of the reasons why it wasn't extremely high. Another cause can be enteral or parenteral feedings, which is deficit in magnesium. Medications could also cause the magnesium to go down. Rapid administration of citrated blood. Contributing causes include diabetic ketoacidosis, sepsis, burns, and hypothermia. Manifestations or things to look for are neuromuscular irritability, muscle weakness, tremors, EKG changes and dysrhythmias, alterations in mood and level of consciousness. So it seems like this is more of a muscular issue when you're too low. And also a ultra level of consciousness. So it seems like it's affecting more the the muscles and the heart, and also the brain. So medical management is basically diet, oral magnesium, or magnesium sulfate. So for the gentleman that I had, if he would have gone a little bit further, I would have probably replaced him with IV magnesium because it was just easier, and he absorbed it a little bit better. Um, So for low magnesium level, you're going to do an assessment. You're going to ensure safety, patient teaching related to diet, medications, alcohol use, nursing care related to IV. So basically, you're going to teach your patient, why they've lost it or what to do to prevent it from being lost and how to fix it. Let's see here. So hypomagnesemia, often accompanied by hypocalcemia. You need to monitor, treat potential hypocalcemia, dysphagia common magnesium depleted patients, and excess ability to swallow their water before administering food or medications. So according to this, the lack of being able to swallow is common with low magnesium patients, and you'll make sure you can swallow well. So having too much magnesium, which is 2.3 or higher, you're looking for flushing, lower blood pressure, nausea, vomiting, hypoactive reflexes, drowsiness, muscle weakness, depressed respirations, EKG changes, and dysrhythmias. So this actually sounds very similar to potassium. Medical management is IV calcium gluconate, loop diuretics, IV normal saline or lactator ringers, and hemodialysis. Nursing management is assess. Do not administer medications containing magnesium, obviously, and patients teaching regarding magnesium containing over-the-counter medications. All right, so I think the last one is this one. So hypophosphatemia. So your phosphorus level is less than 2.5. This could also be caused by alcoholism, refeeding of patients after starvation, pain, heat stroke, respiratory alkalosis, hyperventilation, diabetic ketoacidosis, hepatic encephalopathy, major burns, hyperparathyroidism, low magnesium, low potassium, diarrhea, vitamin D deficiency, and the use of diuretic and acids. So basically it sounds like anything could cause it, and basically I think the medical management is oral or IV phosphorus replacement. So that sounds pretty simple. You're always going to assess your patient, encourage foods high in phosphorus, gradually introduce calories for malnourished patients receiving parenteral nutrition. I think the reason why they bring up the idea of refeeding of patients after starvation is I think that patients who have not eaten, consumed, or had anything in their stomach, the body kind of, I don't want to say it forgets, but it takes a while for it to start back up and actually doing what it was supposed to originally be doing. So I think patients who have not ate in a very long time and their body hadn't really been functioning correctly, I think it almost doesn't know what to do and absorb as much as it should have. So I think the introduce calories slowly is probably more of giving your body a chance to really start to kind of wake up and absorb what it needs to. All right, so phosphate that is above 4.5 is hyperphosphatemia. Causes could be renal failure, excess phosphorus, excess vitamin D, acidosis, hyperparathyroidism, and chemotherapy. Manifestations, few symptoms, soft tissue calcification. Symptoms occur due to associated hypocalcemia. Medical management, treat underlying disorder, vitamin D preparations, calcium binding antacids, phosphate binding gels or antacids, loop diuretics, and normal saline and dialysis. So basically you have too much phosphate and you're either going to fix the reason why or figure out how you can actually get it out of the body. And most likely it's probably either going to be dialysis or you probably could do some sort of vitamin D or calcium binding antacid. The higher the calcium goes up, the lower the potassium goes. All right, so I lied. So there's one more. So hypochloremia is a serum level that is less than 97. This is caused by Addison's disease, reduced chloride intake, GI loss, diabetic ketoacidosis, excess sweating, fever, burns, medications, or metabolic alkalosis. I think for chloride, the biggest thing you probably can remember is that it's more of the GI loss. Chloride is actually absorbed in the GI tract, and if it's not working correctly, then it will actually either lose it or it will actually retain it. So loss of chloride occurs with loss of other electrolytes, potassium and sodium. Things you're going to look for is agitation, irritability, weakness, hyperexcitability of muscles, cardiac issues, seizures, and coma. Things you're going to do is replace the chloride, IV normal saline, with half normal saline. Nursing management is going to assess your patient always. Avoid free water, encourage high chloride foods, and patient teaching related to high chloride foods. So for hyperkalemia, it's a serum level higher than 107. Causes could be excess sodium chloride infusions with water loss. It could be head injury, hyponatremia, dehydration, severe diarrhea, respiratory alkalosis, metabolic acidosis, hyperparathyroidism, and medications. Manifestations are tachypnea, lethargy, weakness, rapid, deep respirations, hypertension, and cognitive changes. Medical management is going to be restore the electrolyte and fluid balance, which is lactated ringers and sodium bicarbonate, and you can also give diuretics. What you're going to do is assess your patient and teach them a diet related to the lack of chlorine and hydration. All right, so the next couple slides is going to be based on maintaining acid-base balance, and this we're actually going to go over in class. I'm going to teach you easy ways to know how to figure it out, what it means once you actually get it, and what to do for it once you have found the problem. Let's see how many slides there are. 1, 2, 3, 4. Oh, so there's only 4 slides. So you can go through those slides, look them over. Read the book, and again, I can only stress enough that the pages that I suggested before that has all the hyper and hyponatremic or hyper and hyper electrolytes on them. Study them, learn them. It does seem confusing after a while because it almost sounds like they all sound the same. Look for the abnormalities in each one of them. Each one of them usually has something that's very specific to that electrolyte. Kind of figure that out and memorize that as opposed to all the other symptoms that seems to be pretty common with everything else. So if you have any questions, go ahead and bring them to class, and I will talk to you soon.